Are there really molecules that are too good to be true? We've been hearing about these now for 2 days, right? We just heard from Carolyn about magnesium. I read her books years ago. It's terrific, makes a huge difference in practice. Vitamin C, I've been using it substantially more since 2011. I never used it IV. I was in the Air Force, and that's a no-no. So not because it doesn't work, but because you don't do it. But we use high dose oral. Found it made remarkable differences. D3, which is what I've spent quite a lot of time in the last decade studying and using. These are all compounds that are panaceas. And the problem is, there's a panacea paradox. We're taught that if something's too good to be true, it's not. And you have to fight that, because these systems, each one you read about, whether it's C or D or mag or iodine, they affect hundreds and hundreds of systems. D3 is known to directly regulate 2,776 genes. That's almost 10% of the genome, okay? I agree with Carolyn's comment about high dose, especially since she said high dose is 50,000. It's very important that people get D levels up, and I'm going to be talking about D, because what we saw happen to D a few years ago, remember, D was hardly on the radar, and then that's all you heard about for about a year. And what happened was really stunning. So are there molecules that are too good to be true? Yes, but they are true. This is a phrase I started using about 20 years ago, because people tend to follow trends. And I tell everybody, don't follow trends. Get on the wave itself. Realize what's happening. I think I'm preaching to the choir here with this group, because you're way ahead of most people on C. I like to start with the take-home point, because you'll know where I'm going to wind up. When deficiencies of substances like D3 and C coexist with diseases, and for the speakers who have talked here earlier and run into the panacea paradox, this is how you combat it. Because we're not talking about causation. We're saying when these disorders coexist, then you notice the diseases will manifest earlier, they'll be much more severe, and the standard treatment that usually works for the disorder won't work. It either won't work at all or it won't work well, until you've identified the coexisting deficiencies and you've corrected them. Then the standard treatments work great. I could have made a career on just taking care of people whose deficiency states, and that's the phrase I like to use, because patients know what a deficiency state is the moment they hear it. Deficiency state management. Recognize that most people are D deficient. Recognize that you have to be C deficient. Have to be, because we can't make it. It's a stress hormone. Mammals make vitamin C as a hormone. Almost all of them. Cats and dogs, horses, cows, pigs, sheep, goats, they make it. They make thousands of milligrams a day. And when they're stressed, they'll crank it up 2 to 3-fold. It's a stress hormone. It's just really unfortunate that we never make it, because we still need it as a stress hormone. And our bodies had to go through some relatively severe compensations, one of which is production of uric acid, to try and make up for the lack of antioxidant capacity that we have. But if you stop and think about C, not as a vitamin, but as a stress hormone, then it brings you to a new level of understanding about how we need to dose people. Because stress hormones, unlike if you consider it like other stress hormones, like cortisol and adrenaline, they're stored in the adrenal gland, just like C, triggered by ACTH, just like the other stress hormones. The problem is we can't make it. We can't make it. And because we can't make it, we have to have a significant reserve. You can only get the reserve if you're not just taking it when you need it. I know a lot of people who take C infrequently until they start to feel bad and then they pile it on. But the reason they're having trouble, in part, is because they don't have enough of a reserve. And so building a reserve is a really important concept when you start thinking about this as a stress hormone. Words have meanings. Meanings usually means a definition. When you think about vitamin, this was defined by Casimir Funk 104 years ago. The substances were defined before we knew they existed, before we knew their chemical structure, before we knew their actions. We've learned so much about vitamins that we've outgrown the term, because the problem that we have now is that people look at vitamins as optional. So when I ask the question, are vitamins essential? My answer is apparently not, because if you ask patients, are they essential? No, they're optional. If you ask your colleagues, are they essential? They'll tell you they're optional. And what position has our government taken? Supplemental vitamins are optional. Do we agree with that? Do you agree with that? No. And the science doesn't agree with it. So we have a real disconnect. And the question is, how do we change that? Can humans make vitamin C as a hormone? Yes. How many people are aware of this phenomenon? Okay. Oh, what did I do? Yes, we do. We make it externally. We make it in factories. Okay. Okay. I kind of tricked you with that. So yeah, we do make vitamin C. You can see it in the drugstores and the like. For me, I was a prize debater in college, and so when someone says vitamin C is not a hormone because we can't make it, I say we do make it. We're the only mammal that makes it externally. See? But what that means is realize also what I learned in pharmacy school before I went to medical school. The pills don't work in the bottle. I tell that to patients all the time. Right? If you want to get better, you got to take them. There are 5 doses of any, when you think about it, any nutrient. There's none. We know that's bad. There's not enough. That's just about everybody. There's the ever elusive, just enough, which when you think about C as a stress hormone, you'll realize that just enough is a faulty concept. It's not going to work for a stress hormone. You can't have just enough because you oftentimes don't know when a stress is coming. So you have to have more than enough. Too much is a concept that doesn't fit. I consider D3 a hormone. I consider C a hormone. It's just a hormone that we can only make externally. So I'm trying to move away from the concept of C and D3 as vitamins, because vitamins have taken on a meaning that no longer fits the science. Something really big is happening with D3. And I think that the same thing can happen with C. But there are some marked differences between D3 and C. But when you look at D3 deficiency diagnosis, it's gone up incredibly in the last 6 years. The sales of D3 have gone through the roof. The 25-hydroxy D, it's not the D3, it's just total 25-hydroxy, is the most ordered single biomarker in America, and it has been that way for 4 years. That tells you it came from nowhere. I mean, I had ordered vitamin D levels maybe twice before late 2006. Between 2007 and 2011, I'd ordered 24,000, okay? 700 to 800 patients got a baseline, a follow-up to assure sufficiency after I'd recommended a dose for them, and a year later to make sure they were compliant. And so when you look at that, you start to realize, it has become the most ordered biomarker. The dose used to be 400 IUs. 5,000 is common now. And there are many patients because of either GI absorption problems or obesity that need 10. Now, when Carolyn said 50,000 is too high, I agree. I don't see a need to use 50,000. If you look at if you have light Scandinavian skin, my grandparents were Swedes, you can make 10,000 a day if you're in your bathing suit at the equator at noon. Okay, you can make 10,000, 10 minutes, but your body will max out at about 20. It won't make more than 20 because there's not enough of the precursor 7-deoxycholesterol to support the manufacture of more D. That's kind of a nice safety mechanism. Your body will regenerate new precursor overnight, but it's not that the longer you stay out, the more you'll make. There's a natural shut-off. The other thing is the liver, which has to do the 25 hydroxylation, right? Keep in mind when you take D, you're taking a totally inert substance, completely inert. It's as safe as anything in all of medicine to take, because the body regulates a two-step activation, and it regulates it with seemingly great precision. So the most telling sign that something big happened with D was this. I keep turning it off. Look at what happened to the reference range. And this is the reference range from this is from Quest. It was slightly different from other labs, a couple of points off here or there, but I wanted to put the same one in over the 4 years. So in 4 years, the lower end of reference tripled, because functionally the lower end of reference is 50. Now, how many folks here are from outside the US? A bunch. Okay. So this is nanograms per mil. I think we're about the only country on the planet that uses that. I think everybody else, 95% of the world, uses nanomoles, okay? Just take these numbers and multiply them by 2.4, 2.5, okay? That'll get you to, so in 80, for example, roughly mid-range, 80 nanograms would be about 200 nanomoles for those who are in the sane part of the world. But when you stop and look at this, let me just ask a trivia question. What other substance has ever had this happen? 4 times, 4 years. Lower and upper go up. Can you think of any substance that's had a reference range change like that?
Iodine.
Reference range? Are you talking about what, serum or urine?
It was urine.
Okay. I'm not aware of that, but that, I used a ton of iodine. I always used the urine challenge test, 50 milligram dose, 24-hour collection. But that's great to know, though, by the way. Because when Carolyn was talking about iodine and too much and it does stuff, she and I got to talk about that one. Iodine unloads almost all the heavy metals, and it does it in extraordinarily good fashion. We lost almost all the iodine in our diet in the mid-1980s. Used to be in dairy, used to be in bread. It's gone. We vilified salt, so people aren't getting it through the backup mechanism, iodized salt. So everybody's iodine deficient, everybody. And we see that in rates of hypothyroidism and obesity, dementia. So we've really goofed ourselves with that one. I am good at this. There we go. Self-monitoring is the way most stuff's going to go in medicine because it's too expensive to see the docs. The D3 hormone, you can check. There's, I know CRT as a company makes these little pads, and I think through grassrootshealth.com you can get them on a discount oftentimes. So it's the most expensive, least expensive way to do it. It's convenient. You do it in privacy of your home. It's just a finger stick. At this point, I wanted to mention that D3 and C are very different, not just because we make D3. Now, we don't make it often enough. And what's the number one reason why we don't make D3? We don't make enough. Number one reason. I've never had an audience get this right. Mammals, we're the only mammal that wear clothes. Think about it. We cover the organ. So you can't make it. You can't make it because we wear clothes. D is a stable molecule, very, very durable. Durable starts with D. It has a really long half-life, 3 weeks, 3+ weeks. And although you can have a serious stress like sepsis, okay, your D levels don't draw down. It's not a significant drawdown. Think of how different that is for vitamin C, okay? C is fragile. It degrades when it's exposed to air, to light, heat, refrigeration. It's a very fragile molecule. We can't make it ever. And what happens when our demand for C goes way up? It tanks. Our levels tank. And it's not uncommon for them to go to zero, a zero plasma level. Now, you might think, how can you survive with a zero plasma level? And I'll tell you, you just have to think about an investment concept called cash flow. A company can be unprofitable, but they can stay in business because they have cash flow. It's not good, and in the long term, it'll fail. And that's the way we are with C. We kind of get by because we are getting some C. If you got no C, you wouldn't make it. The plasma vitamin C level, by the way, needs to be ditched because it makes no sense, right? We're one of only 4 mammals that don't make this as a hormone. Why in the world would we use as our reference us? Right? Makes no sense. We should aspire to be more like the goat. So to improve C status, there's 2 things you can do. The first one is obvious, and I think most people understand that. You can increase the dose and frequency of C. The second one is less obvious. I started talking about this 5 or 6 years ago. I was a regular speaker at the National Military Family Practice Conference, Army, Navy, Air Force, Coast Guard, Marines, and public health officers. And I pointed out to them that if you want to have a good C level, you have got to have a good D3 level. It's imperative that you have a good D3 level. And the area that I shoot for is 80 nanograms per mil. Outside of US, multiply that by 2.4, about 200. Why increase D3? Because D3 spares C. The D3 hormone amplifies the glutathione production. Glutathione is one of the most important antioxidants, so that when your vitamin C gets oxidized, if it doesn't get reduced, you're going to lose it in your urine, right? You got to get it reduced so it can go back in the white cell, because that's the only place where it's safe, in the white cell, because we don't pee out white cells, do we? So, and white cells are what carry C to target. To me, it's always been similar to oxygen and the red cell and hemoglobin, okay? So it's not the plasma level of vitamin C that determines how you do, just like it's not the oxygen tension in an arterial blood gas that determines what you do. It's are you delivering it through the cells that were designed to carrying it? So the white cells carry C, the red cells carry oxygen. When you stop and think about recycling, recycling has the greatest potential to help improve vitamin C, because if you can recycle each molecule once, you doubled it. If you can recycle it twice, you tripled it, okay, without having to take any more. And all mammals have this glutathione mechanism where they can recycle C. So we've got to start stressing that, and we have to be addressing D3 levels. It's one of the only ways we can attain any kind of improved vitamin C status. Otherwise, you're left doing what Linus Pauling suggested, by the way. I mean, I was a chemist before I went to pharmacy school, before I went to medical school, and I tell you, he's a hero to me. I mean, the man had figured a lot of stuff out. D3 wasn't known. There wasn't a decent test for the stuff until 1996. So the words that work, D3 I call the guardian hormone. It regulates about 10% of the genome. About a third of that is well understood with great precision. And there's a definite pattern, and that is when D amplifies a gene, that's good for us. When D is suppressing a gene, that gene's bad for us. So I tell my patients that D3 is the guardian. We've all had C intravenously, right? Everybody here in the room's had IV vitamin C? Anybody who hasn't? You did. Yep, you don't remember it. It's the first 9 months of your life, okay? You had IV vitamin C when you were in utero. Now, I don't say that as a joke. I say that because we have to rethink what we're thinking about with C, because all we're thinking about is oral. Now, here at this conference, obviously, you're here to talk about IV vitamin C. But IV vitamin C isn't the exception. It's the rule, because all these other mammals make it, right? They produce it in the liver. How does it get to the organs? Intravenously. Intravenous C should be our model. It should be what we aspire to, because trying to do this orally is very, very difficult. There are times you have to do it, because as we pointed out, doing an IV is not an easy thing. But we got to lower the bar so that people are doing IV vitamin C a lot more quickly. And that's going to take a lot of effort. I tell folks that the way I conceive of it is, before we could make vitamin C as a hormone, we had to imagine it. So I think of C as a virtual hormone first. That's a phrase that the millennials love, virtual anything. So C is a stress hormone, and I agree with Ron, think C, but don't doubt D, okay? And this will make a big, big difference. Now, I've got 10 subjects here. How am I doing on time? Doing okay?
Okay.
3 minutes, oh gosh. Maybe a little more. All right. Here's 10 things, okay? This is where you get to pick what you want to hear next. I'll do it in less than 2 minutes. Who would like to hear one of these? Jellyfish. That's entitled, Can You Make a Difference? So I was on a web service years ago when you're no longer, I retired, and so I inactivated my license. And when you do that, you can't be a member of a group called CERMO. CERMO's a physician website with blogging. Sometimes it's very good, sometimes it's evil. But one of the things I found interesting was there was a story there that was put out with lots of photos from a plastic surgeon in Florida who had had a male patient who had had a jellyfish attached to his chest. And he was taken by ambulance to the hospital. They worked to get the jellyfish off. There was a terrible envenomation. The patient was in horrible pain. They administered narcotics and started IVs. And the long and the short of it was the patient wound up needing extensive skin grafting. So they took large sections off the anterior thighs and both buttocks just to cover the chest. It looked awful, awful. I saw that article, and so I sent a private note, not a public one, to the author to say, thanks for writing about this. You may be interested in this article I saw a couple years ago in the Australian Journal of Medicine. There's at least one person here from Australia, right? Right. It was a Malaysian story published in the Australian Journal. A patient also had been in the water in Malaysia, had a jellyfish attached to his chest. He wasn't picked up by a hospital. He was taken to a tent on the beach where they put a substance on there which makes the jellyfish let go quicker, so there's less envenomation. At the same time, another person was starting an IV. What was in the IV? C. Pain was gone in minutes. They treated for hours. Told him to go downtown, get a prescription, or pick up some over-the-counter C and take as many thousands of units during that night. Came back each of the next 2 days to get 4 to 6 hours of more IV vitamin C. No scars, no pain. Malaysia, America.
I mentioned to her about the fact that about 3 or 4 years prior to that, I treated someone who had burnt their hand on a hot pot.
Right.
And at the end of 2 treatments for that individual, the blister released, and there was reepithelialization on the hand. So I told the mother, I said, I didn't know what to expect. I didn't know how soon it would be, but it makes sense to me to give him some C because that's collagen production
Right.
and new skin formation.
Yep.
He had 5 treatments, and in a 3.5-week span of time, the wound completely healed. By the 3rd treatment, he was minimally pain-free.
Right.
Had he been treated just with the topical Silvadene, this boy would still be incapacitated.
Right.
The mother, at the end of the 2nd treatment, took the boy to see a plastic surgeon. The plastic surgeon looked at him and said, okay, the hair follicles are still there. Keep applying the Silvadene. I said, what? End of the story. The kid is
Yeah.
healed.
Well, thank you. Yeah, I have a book. It's a 1956 edition of a Merck medical manual on vitamin C. It has little short paragraphs describing each of the articles that have been published since 1940 to 1955. Because what I wanted to know was, what do we know about vitamin C, and when did we know it? It's incredible what we knew in 1956. I bet 90% of what was known in 1956 isn't known today. It's fascinating, fascinating stuff. The seizure control, that was another Sermo case. By the way, so I sent the private note to the plastic surgeon, didn't hear back for a couple of weeks, so I figured, he blew it off. Nope, he was studying, he was calling people, and he sent me a note back and he said, I won't do it again. See, but I thought I didn't say this to him, but lots of luck getting it through your P&T committee. If I've only got a moment left, let me tell you a little bit about what's happening in Atlanta, Georgia. Because if you're gonna have major trauma, I hope it happens in Atlanta. And if it does, have a little card in your wallet that says, take me to Grady Memorial Hospital. Fascinating. Ray Matthews is the director of trauma there. And a friend of ours, mutual friend, contacted me and contacted Ray and said, you two guys need to meet. And so he picked up the airfare for me to fly there. I said, I'm retired, Ray's not, so it's easier for me to go see him. So the two of us flew to Atlanta. And he said he had set aside a day. He's a director of the trauma unit at a 1,000-bed hospital. But boy, does Ray have numbers. Because when he left the Mayo Clinic training program and he went to Grady, he knew that he needed to give people vitamin D in the ER. It's one of the first drugs they get. He uses a lot. I didn't want to correct him because he has great data. I would have looked like an idiot explaining to him that he can only 25 hydroxylate about 15,000 a day, so giving 50 is, I thought, heck, he's got the numbers. I'm not going to argue with him. But I did ask him, what are you doing with vitamin C in these trauma patients? Shot 10 times, run over by a car, beaten up by a gang. I mean, they're near death. What do you think their plasma C was? Zero. So I said, what are you doing with C? And he said, well, we give them 1,000 milligrams a day. And he quickly followed that by, Dave, is that enough? And I said, no. And he said, how much do you give? And I said, more than enough. You won't know until you test. So he immediately started testing his patients on admission with a plasma vitamin C, and then every morning at 8 a.m. Less than 2% of the patients had a detectable C, right? Cash flow was keeping those patients alive. The 1,000 milligrams a day that they gave didn't change it. It was still zero. So he did what any good surgeon would do. He doubled it. He went to 1,000 twice a day. And when that didn't work, he doubled that. And he doubled it again. He finally realized you can't move the needle in these trauma patients orally until they've had 4,000 twice a day, okay? And he also noted that on whatever day it was that the C level went from not being detectable into the human range of reference, that's when the patient's crisis turned. And he knew that in 3 days they'd be out of the ICU. His mortality last year, trauma ICU, 3%. 3. It's 25 at trauma centers, level 1 trauma centers. I think he has the best results in America. And he did it using everything else that everybody else was using. And all he added was D3 and C. And he's given the C orally. I've been saying to him, someday you'll go IV. And he said, you know how many battles I had to fight just to get them did D, right? Orally. So he's got the data now. The other quickies, mothers and babies, keep in mind that the placenta, the temporary organ of pregnancy, has the highest concentration of C of any organ in the body by far, because you can't make new cells without C. Babies are all new cells. Organs with the highest C, after the placenta, it would be the adrenals. That's where it's stored. After that, eyes. I tell my patients and the ophthalmologists and optometrists that I train, you can't see without C. And you know what? When you have people who have borderline ocular hypertension, right, glaucoma, and you just have them take 1,000 milligrams a couple times a day, their pressures normalize. And I've got optometrists now doing that. How many people have been kept off a diagnosis of glaucoma with that? It's not complicated. Scurvy can be acute or chronic. Chronic supply side is what we learned as scurvy, right? You have nothing coming in. But remember, there's only ever been 2 studies on scurvy in history. One a British study in sailors to find out how much C they needed to be putting in the lifeboats. And the other was in an Iowa penitentiary. Those are the only 2 studies that have been done. And they were just trying to see how little C could they use. But the studies were done in patients who had been given luxurious amounts of C for 70 days, for 10 weeks before the study began. So the studies available on scurvy have nothing to do with the people we see. Nothing, because nobody comes in 70 days preloaded and suddenly gets none. So if we're gonna understand this disease, and I would suggest that everyone in this room has seen somebody with scurvy. Everybody has, okay? And it goes under 100 different names, but it's there. Acute scurvy, down the list. Could Ebola patients be dying with scurvy? I'll be shocked if they're not, but they're not even being tested. The strips that the Riordan Clinic has here cost 22 cents, and you get the results in 30 seconds. So I went up the chain and started with my public health officer in the county, who gave me a verbal introduction over the phone, to the state public health officer, finally to the CDC public health official at Fort Collins. So it's my belief that with the next Ebola attack, they're gonna have the dipsticks. And I said, the kind you use. It's very likely that the patients with Ebola are dying with scurvy. I didn't say from scurvy. It's with scurvy. Next time you have a moment, look up the symptoms for terminal Ebola patients, and look up the symptoms is scurvy. They're the same symptoms. Hemorrhage, right? I mean, Ebola is hemorrhagic fever. The fever is the first symptom and the hemorrhage is the last. Average life expectancy from the first symptom is 10 days. So if we're going to save any Africans, we're going to have to do it IV. That's being considered at high levels. Do you want a big scar? How many people here do preoperative counseling of patients to clear them for surgery? Okay. So when you go to clear someone for surgery, you want to make sure they're not going to have a heart attack. You want to make sure that their neck can move so they, can be intubated properly. And then the question is, I always ask patients, do you expect to get a scar from your operation? And they say, sure. And I say, would you like it to be a really big one? And everybody says, no, I don't want it to be a really big scar. So I explain to them that if you're D deficient, you're not going to heal your wound well, and you're likely to get infected. If you're C deficient, you can't make good tissue. Scar is an abnormal response to healing. We only scar because we don't have what we need to heal primarily. And my wife's one example. They don't mind. She had hip replacement surgery as a young woman, and has virtually no scar. And it's fun because whenever she goes in to see her orthopedic surgeon for her annual visit, he always looks at one side and says, "I'm sorry, I got the wrong side. I must have," you know, 'cause he can't find a scar from the hip surgery replacement. And it'll be that way with most patients. You'll find that the African Americans who get the rope keloids, the keloid is just an abnormal response. I said it takes D3 and C, right? What are the D3 levels like in African Americans? They're 40% lower than whites. Whites have terrible levels. African Americans average less than 16. They're all deficient, 100%. So these are things that we can do. Asthma is a two-component disease, bronchospasm and inflammation. The inflammation we know is due to cytokines. And D3 suppresses cytokines big time. So when you take your asthmatics and you put them on D3 and you crank them up to about 80, which is the middle of the range of reference, and then magnesium deficiency is what's responsible for the bronchospasm. I'm sure Carolyn agrees with that. So you get the asthmatics with a level of 80, and you get them some source of magnesium. Epsom salts is the cheapest and the easiest if they're willing to take a bath once a week, and they don't wheeze, and they come off their medications. How many of my patients came off their asthma drugs? I don't know the number. It was all of them. Every asthmatic came off of medications, even the ones that had had it since childhood. This is a metabolic disorder, and it's because we're D deficient and we're magnesium deficient. So thank you for your time.